and a very good afternoon to all. This particular topic of sterilization, I'm going to choose to focus on some issues which have been brought to the attention of the world. And these came about because of stories that we've heard, stories that are published in the literature, and also it could be the newspaper. So if I could just move on to the first story, and this is a very recent one that was published this year in August, where we heard of an incident in Canada where they've had a patient who went for dental treatment, and unfortunately within a month, kind of developed hepatitis C. And when they did a look back, they found a second person who happened to have chronic hep C infection, but who was in the same facility the day before. And so that kind of, stimulated a lot of investigation, as I showed you here in this first slide, where they actually tracked back and uncovered about 264 patients, did lots and lots of investigations, serial kind of blood tests, so you can see all these results. But the good news is that they didn't find anybody else. But they found a lot of things when they kind of reviewed what goes on behind the scenes for the reprocessing of those dental instruments. So these are the many findings. And when you look at it, it's really fascinating because it covers practically everything. There's the physical layout, there's the processes, of course, starting from the beginning as to how you kind of disassemble and put it together, how do you clean it, how do you pack it, and before you pack it, you kind of, put in the right stuff to monitor, and are there some kind of documentation, to show you that they are really looking at things hard and correcting them. And interestingly, on the right-hand side, you could see that there are other interesting processes where people are doing things that they're not supposed to do in their kind of routine clinical work, like medications are pre-drawn and not labeled. This is a no-no that we are very well aware of in the patient safety era. The use of PPE and so on and so forth. But the last bullet is interesting, that they found that there's no one dedicated to overseeing infection prevention and control in that facility. And this occurred in a dental setting in Canada, in a developed country. And so it brings a lot of interesting lessons. And I would say that when you kind of scout around the world, you would hear similar stories. So I show you another one in Asia Pacific, and this time it's Hong Kong. And this is published in an Asia Pacific journal, as you can see, Journal of the Formosan Medical Association. But when you read the account, it kind of rings a bell because it says, when you looked at it, it sounds pretty familiar. Here is a setup where, the incident occurred on October 30th, but nobody took note of it until it was reported like 2nd November. So there was a delay in reporting. So by the time they knew it, which means a lot of instruments which did not get processed properly gets released and used on patients. So that, of course, caused a stir, lots and lots of investigations and callback. And when you look at the drawing of the layout of the whole dental setup, it looks pretty simple, very neat. And you said, yeah, this is probably what you expect, a clean zone, a dirty zone, and so forth. But when they show you the pictures, I think that's where you begin to kind of understand what could have happened in that facility. It is small. It is crowded, right? And there are lots and lots of things there, and probably not much space to work around. And, with a busy setup, there are possibilities that many things could go wrong. And in their own investigation, it's like the first incident. They found many, many interesting lapses in practices in the whole SOP of reprocessing. Closer to home, we've had our own fair share, and this time it's not reported in the medical journals, but it's the newspaper. Okay, the first one in the National Dental Center in 2017, and a year and a half later in another facility, And interestingly, in the 4 stories that I told you, is all about dental facilities. And this is where the attention is drawn. You know, we have sterilization units. Who actually runs it? What goes on there? And do people really keep an eye? And all these small facilities, you know, reprocessing dental instruments, they are small. There is a possibility that they may not be kind of in a good, kind of a centralized setup. So that's where things may go wrong. But when you review everything, the common gaps that we see in all these stories is design and layout. This is one area in which we are learning lots and lots of lessons, even during COVID, you know, in concerning ventilation and so forth. So it's the same. You know, reprocessing unit, it's not a factory. It's a proper facility where we had to process instruments. And so the design and layout is critical, like what we saw in the earlier stories. It is critical that people who work there understand sterilization and disinfection. They really understand what is sterilization and the risk factors, you know, where things could go wrong, and the importance of cleaning even before sterilization, you know, and the importance of verification and the important aspect of monitoring, whether you use biological and chemical. All these are very, very important points. And so I think that's why, you know, attention also has been drawn not just to facilities, but practices and guidelines. So I just want to move on and talk about other common incidents. And in the dental practice, a lot of soaking is also being done, you know, because these are fine, delicate instruments. And sometimes, you know, you want it quick, so you don't want to do heat sterilization. Although heat is really the best. Steam sterilization through all the years is still the best kind of technology. But these days, we have new kind of technologies. Yes, we have cold sterilant. We have all kinds, you know, whether it's a glutaraldehyde or hydrogen peroxide or peracetic acid. But these must be used according to manufacturer's instructions. So really attention has to be paid to the small print. How do you use it, in what concentration, and what duration? So safety and efficacy are grave concerns, you know, for if you're really using a cold sterilant. Whereas for steam, you know, everything is run by the machine. It's kind of predictable, you know, and you can rely on it. Secondly, with respect to cleaning, I've mentioned verification. And this is an exercise which we took in our hospital to kind of test, you know, how clean are the instruments really when we clean them, putting it through the washer disinfector. If you haven't seen a washer disinfector, they are huge, you know, and there are multiple jets of water, and they function like a huge dishwashing machine. Okay, so you have these jets of water at high speed, you know, being thrown at the various instruments. And so the understanding is that, you know, if there's any debris on those instruments, it would have been washed off, you know, and plus the high heat. But does it really clean those instruments? So the CSSD at our hospital, we went to do a study, and this is the paper that we published in a Canadian journal. We were validating 4 kinds of instruments really, and looking at 4 verification tools, including the usual one where you just look at, you know, visual inspection using a magnifying lens and light. But importantly, relying on more objective kind of tools like the ATP and protein residue. So I'm going to show you our results, where the first one is the Ronger instrument, looking at the number of, you know, bioburden just before cleaning, you know, right? And as I flash the instruments to you, like the scissors, the tube suctions, and the handpiece, I think you would realize that these are instruments that are not so easy to clean. Okay, they have crevices, you know, and so you may have to kind of loosen your instrument a bit. And obviously there needs to be some brushing, you know, and with those tubings and so forth. And the handpiece can't go through heat and so forth. So you have to manually wash them. So they pose challenges. So what did we find? And so the first phase, if you can see the ATP count, and it's read in the RLUs, okay, so the first one, before cleaning and post-cleaning, there is a dramatic drop, but it's still 4-figure, 2,744. That's huge, all right? And to give you an idea, what is reasonable? Well, there isn't really a reasonable number at the point in time when we were doing the study, but we were looking at the food industry, and they use ATP as a quality marker of cleanliness for food hygiene. And the figure was 400 as a cutoff point. So it's 400 and 2,704, that's a huge difference. So it is still quite high bioburden. So we looked at it and said, what else could we do? And so the picture on the right shows you the ultrasonic washer. It is a common item in any CSSD. So we asked, how did you use this? Why don't you use it? I mean, these are machines that shake the instruments, and so, you know, it really helps to dislodge some kind of organic material. And so you notice the results for phase 2A, the number dropped further. So that does help a bit. And we said, why did it drop further? How did you do it? And so through our observation, what we discovered were the cleaning tools, you know, and I showed you a picture on the right. There was a variety of it, but look at the condition. You know, some, obviously, the bristles of the brush are not really of good condition. And so we had that corrected, and we kind of told the people, you've got to really pay attention to your brushing and so forth. And look what happened. The final result, you managed to get a 2-digit number. Okay, so basically what is being shown here through this simple study is the quality improvement effort to take to review the process, you know, and really painstakingly looking at the processes and giving kind of advice in correcting and closing the gaps. And so we did the study, we published it, and interestingly, other people are doing similar studies, and I showed you here an Italian paper that's published this year, and they were looking at 140 instruments. You know, we were just looking at 4. But they were looking at different kind of instruments here, and it's pictured here on the left on the table. And you can see that these are really small instruments, and they have grooves at the tips of the forceps and the needle holders and so forth. And they tested 2 points for each instrument. And through all these steps, they were looking hard, analyzing it and inspecting it. So there's step 1, 2, 3 of inspection, and they collect the ATP reading. So here are the findings. What do we see? Well, there's a lot of variation, right? Lots and lots of variation in terms of the readings. And it's actually not easy, all right? So as I showed you before, you know, it does take quite a lot of effort, even in that manual cleaning. And so many people have turned to use the simple ATP as a marker to help them in kind of analyzing, are we really cleaning it properly as we should? And so in the APSIC sterilization guidelines, we wrote this, you know, that the cleaning verification should be part of the process, you know, in the reprocessing of instruments. And that should be done pretty regularly on some selected samples. And so people may choose a certain number each week, you know, or 30 a month and so forth, but it is done regularly. It's recorded, documented, you know, but it's a whole exercise of a quality improvement kind of process where you understand what's going on in your facility and therefore be assured that there is some degree of quality cleaning. Another aspect is in the area of monitoring. And I show you here a table, you know, which kind of describes the various chemical indicators that we use in sterilization. And unfortunately, this table, you know, although it describes many things, most people don't read everything. And there's often the misunderstanding that the bigger the number, the better it is. Unfortunately, it is not, as I will show you here in this picture, because there's usually a huge confusion over type 5 and type 6. You know, and honestly, type 5 is the better indicator because, as you could see in this time curve, you know, where the reading is really, you know, above the thermal death time for the kind of stereothermophilus indicator. Whereas for your type 6, that's where at some temperature, you know, it crosses, and therefore you don't really have a reliable mark of assurance that you have really killed everything. And if you were to use a type 6 indicator, you have to look at the instructions given by the manufacturer in terms of at what temperature should this be used. Because really in the real world for sterilization, you could be sterilizing at 121, you could be sterilizing at 134, and so, you should use the correct indicator. So that's why you'll find in most kind of guidelines, most people would recommend a type 5, all right, as a good chemical indicator, pretty close to a biological indicator, although it does not replace it. The other aspect is in terms of where should you put these chemical indicators, and so, yeah, you should put it at a place where it's difficult to process, most people would know that, but, chemical indicators are there for the users to read it. And it's interesting through reviews that we have done in our processes at various hospitals, we learn, there are people who are more knowledgeable, and that's because they work in that area or they kind of are familiar with the products. But there are other areas in the hospital who may not really pay too much attention to sterile products. And so when they are asked to read a chemical indicator, sometimes they don't know how to read. What color should I look at? Before I realize, is this the right color or the wrong color? Okay, because when you go back to your hospital and you look, you have different types. They're all different colors, and so this can be pretty confusing for people on the ground to understand. And so most hospitals by now, would have come up with a table to kind of educate the staff. So this is an important point too. So finally, it actually boils down to whether, staff are really knowledgeable, not just the people in the reprocessing unit, but of course the users and so forth. But in my talk, I'm really focusing on people who work in sterilization facility. And so in the APSIC guidelines, we put that the supervisor is someone who really should be certified in sterilization and disinfection, meaning this is a person who has gone through some training, sat through an exam and passed, okay? So gone are the good old days where you have someone, who is trained in operating theatre, she's a senior nurse, she's worked in the hospital for a long time, and she's promoted through the years, and she runs a CSSD. That's not good enough. We really need people who are competent, and similarly, the competency should be the same, in good, documented for every person who works in that sterilization department. So I think this is where guidelines are important, and I've mentioned the APSIC guidelines, which was published in 2017, and that is a pretty comprehensive one. It has helped many people, but we realize, especially during COVID pandemic, where, well, it's a respiratory tract infection, and so the dentists are pretty worried, if they have patients who have ARI and so forth. And we've heard also of how, a lot of dentists unfortunately succumb to the disease in some developing country. So this is where we're learning that, quite interestingly, there's very little written about infection prevention control guidelines for the dental setting. And so APSIC has started to work on this. We are on the final stage of finalizing it and should be publishing it in 2022. So look out for that. So going back to the APSIC guidelines on sterilization for acute care, so you can read more of the guidelines in our website, and also in the ARIC journal, which was a good summary of it. But I'm showing you here an implementation tool, because we realize, guidelines, it's easy to write, but not easy to implement, as we've seen from those 4 stories that I've told you, because there are many, many factors. And so we came up with this checklist to help people to kind of self-assess. What is it like for my facility? Am I okay on the right track if running this facility, in operating it? So there are several checklists to go through, for the people who work there. And I'm just showing you one example here with respect to handling, collection, and transport. So the guidance is that people will do their own self-assessment, run a gap analysis, and then close the gaps using a quality improvement process, and then to kind of run this regular review, at least on an annual basis, to see how you move on. Because some of the things are easy to change, but some are difficult because it needs some money. Whether you got to buy a new sterilizer or you got to run some renovation to the ceiling or to the floor and so forth. So when we implemented, or rather when we launched the APSIC sterilization guidelines, we had in mind not just for self-assessment, but also to kind of encourage people to really go out, and go for excellence in standards for your practice. And so we ran this award. It's called the APSIC CSSD Center of Excellence Award, where we ask people, you've seen the guidelines, you kind of try to implement it, you do your self-assessment, and tell us, if you think that you are doing reasonably well, come up and apply for this award. And what happens is that, we will recognize an excellence center as described in this case. And so this is run annually. People can apply for it. And the closing date is actually in the month of April of each year. And so the winners will be selected, by 2 auditors who visit on site. And we've done this for various countries since our launch, and I'm happy to tell you that we've got 35 winners so far, and so we've started an alumni. And these winners are recognized at the APSIC Congress. And the next APSIC Congress is right here in Singapore next year in July. And so I really look forward to more people participating in this. So in conclusion, I'd like to say that, for things to go right, especially in an important process like sterilization, like what the guideline says, it should be centralized, not just for cost effectiveness, but really to be run by people who know what they're supposed to do, they're competent with all the nice monitoring processes and so forth. But that journey may take some time for people, but it is a progressive journey and it can be done, it can be achieved. All we need to do is to run our own risk assessment, self-analysis, and then just closing the gaps and making sure people establish kind of staff competency, if you haven't done so. But last but not least, is really to reach for the stars, reach for the excellence in practices, because it's all about patient safety. Thank you.